Thank you, Dr. Tarun, Dr. Anmol, Dr. Ashish for inviting me here. And I'll try to bring out something about the classification of these fistulas and how they are relevant to how we manage them in these cases. Greetings from Maulana Azad Medical College. And it's not working. Okay, so why do we need to classify? There are various reasons. I mean, the basic would be when I talk about a particular type of fistula, the other should also understand what fistula we are talking about. So that is an intercommunication like between the radiologist and the surgeons. When the radiologist is talking about something, do we understand it's the same thing or not? And then we have something like follow-up and research. So etiopathogenesis has been talked about. So that is the gland. It can form an abscess. So usually it's in the intersphincteric space. So about 70 to 80% of problems you will encounter would be in this area only. So it can progress, rupture down onto the skin, forms a simple straightforward fistula which we all love because they've got very excellent prognosis. You do any procedure, they have a good result, right? But on the other hand, you can have, like very well described by Dr. Kamal just now, abscesses going here, there, and when they rupture, they can form all sorts of difficult fistulas, which we have problems in treating. But what you have to understand, what is the basis for this classification? We can either have a purely anatomical classification, so that's what we usually follow, or we can have a functional classification which will tell us about the problems which we can face or the prognosis of the disease. Just like any other disease, it's the same here also. So the basis you have to understand, firstly, you divide the internal sphincter, that's this internal sphincterotomy. It has largely no consequence. I mean, I'm leaving out the elderly and so on, but largely it would have no consequence at all. Right? That's the first thing to remember. Secondly, it is understood that if you divide about the lower 1/3 of the external sphincter, usually there would not be any significant incontinence. That's what we are worried about. Otherwise, the fistula surgery would be very easy. But we don't want incontinence. So the lower 1/3, if you take the length of the sphincter to be 3 to 4 centimeter, that means in practice, you can divide not more than 1 centimeter of the external sphincter. Right. Now, if they are crossing the levator ani or anything else, that makes the surgery much more difficult. So there have been a lot of classifications over the years, but the earliest and the easiest which we learned, which used to talk about during my postgraduate days 30 years back, was either a low fistula or a high fistula. And there are a lot of things we have talked about over the years based on fistulograms, based on clinical examination. Now a low fistula generally is when we do a fistulotomy, whether it will result in incontinence or not, and that is a low or a high. So that is, like I said, about 1/3 of the external sphincter. So the things really changed when Parks came out with his paper. This was in 76 when he gave the classification for fistula and ano. This was largely purely an anatomical classification, and this is the way the 4 groups has been described. We still follow that, and it largely does the job. Whenever there is a component of the next, I would say the grade, the higher grade is taken into consideration. That means if any component is crossing the external sphincter, we call it a transsphincteric, even if the most of it is in the intersphincteric region, right? So the higher grade will define what grade we are talking about. So coming to the intersphincteric fistulas, which have been discussed, this is the most common. That's good because 50 to 70% you do a fistulotomy and the patient is fine. That's a great thing. Internal sphincterotomy. A fistulotomy here is essentially an internal sphincterotomy when there is a purely intersphincteric fistulas. And this leads to most of the others, so that is why you need to know about the space, how it spreads, and how to manage these cases. What the diagram shows where it is purely present. But this is being the classical intersphincteric fistulas. You have a lot of variations to this. It can spread up, down, limited entirely here, or going right up to the colon. But note, in all these varieties, it is limited only to the intersphincteric plane, right? I mean, the sixth one is a difficult thing to treat, but it is limited only to the intersphincteric plane. It is not going outside the external sphincter. That's the most important part of the internal intersphincteric fistulas. Then we have transsphincteric. Whenever a tract crosses the external sphincter, it is a transsphincter. Be it one of the tracts, be it one of the ramifications, be it an abscess, it is always a transsphincteric fistula when the external sphincter is crossed. It is the second most common. So if we include the intersphincteric and transsphincteric, you have covered more than 90% of the cases you are going to encounter. So right, the second figure shows that there's a big abscess, ischiorectal abscess also, which may actually extend supralevator also, but it has to be crossing the external sphincter at one point or the other. Suprasphincteric and extrasphincteric are less common. So suprasphincteric when the tract curves over the external sphincter. So if it is curving over the external sphincter, now you have got a couple of practical problems. Firstly, you obviously can't divide this completely. Secondly, passing a probe also becomes difficult. This curve over going up and down and finding the internal opening, that becomes difficult if you are trying to probe that area. And extrasphincteric is a couple of varieties. Now, all the earlier ones were because of the cryptoglandular theory. That means there's a glands which get inflamed, infected, form an abscess which ruptures, or an IND is done and it forms a fistula later on. Now, for extrasphincteric, there could be other causes also. Like it may be Crohn's disease, diverticulitis, tuberculosis. All these conditions may lead to extrasphincteric also. Right, so this is the most difficult, and yes, they are supralevator, they cross the levator, they are going beyond the external sphincter entirely. They may have a component of a transsphincteric also, like in the first image, bottom left. But as long as it has a supralevator component, they are always classified as an extrasphincteric ones. So some problems with PARCS was, what about horseshoe abscesses? What if there are other abscesses along with the fistula? What about complex fistulas, extent? All these issues were not really addressed by PARC, but still remember PARC classification has stood the test of time. In 96, the American Society of Colorectal Surgeons thought, why this anatomical classification? What we are concerned about is how to treat and how to what is the prognosis of these patients. So they said, let's forget about this anatomic and we'll just divide it into two categories. It's either a simple fistula or it's a complex fistula. So what we used to call as low fistulas were called now as a simple fistula, and complex were all others. So a simple fistula is simply, if you do a simple fistulotomy, the patient will not have incontinence. That is a simple way of understanding. That is a simple fistula. If there is a possibility of having incontinence, or if there is some associated conditions like Crohn's, tuberculosis, or in women who are already having anal incontinence, they all come under complex, and the prognosis for complex would be slightly guarded. There's a higher chance of recurrence, complications, incontinence would be there. So along with this, again in 96, MR was coming up in a big way. Now they were having a problem. How do we classify? I mean, what they are seeing till that time, what we were used to were the fistulograms. Inject some contrast into the fistula and take X-rays and take the line and pubococcygeal line and see whether the opening is below that, above that. It was not really a good thing. I mean, hardly anybody would be even knowing about those tests, but we were quite inaccurate with those. When MR came in, they thought, how do we differentiate? How do we classify this? And then came the St. James University Hospital classification. That's just what they were using, and this has come into use. So whenever the radiologist talks about it, he's talking about these. They call it as the grades. So grade 0 to 5. And you would see that they follow the same as the PARCs. I mean, grade 1, grade 2, both are intersphincteric. Grade 3, grade 4 are both transsphincteric, and grade 5 is everything else beyond that, be it supraelevator, suprasphincteric. So instead of extrasphincteric, they call it translevator, and instead of suprasphincteric, they call it supraelevator, but means more or less the same thing. So when the radiologist is giving this report that there is a grade 3 transsphincteric, it's not very different from what you already know. It's a PARCS classification, which we are talking about. So this is just a diagrammatic representation of, again, it's the same thing. So grade 1, 2, 3, 4, 5, 1 and 2 are both intersphincteric, and 3 and 4 are both transsphincteric, and grade 5 is everything else. Beyond that is grade 5. So if you get a report of a grade 5, be worried. So, and then we have Dr. Pankaj Garg from Panchkula, who's published extensively on fistula and anos, and based on his cohort of, this was in 440, but he's got more patients, crossing more than 1,000 patients now. in which he applied all these classifications, and he found that there were problems with these classifications, that if you do fistulotomy thinking that's only a intrasphincteric or it's only a transsphincteric, less than 30%, it would still not be applicable to all the cases. So he brought his own classification. It's published at a number of places now. And again, it's an extension of the same Parkes classification. So it's an intersphincteric, transsphincteric, but he's added another factor of whether there are abscesses along, whether it is in women or there's incontinence, so radiation has been given before. So all these things have been graded. I just took a copy-pasted his table from his publication, and you can straight away see it's a bit complex. So I would say it's probably the best classification for research purposes. When I want to publish and compare my results with somebody else, then I would say this is probably the best classification. In practice, I usually find that the Parkes is good enough, with the understanding that we hardly ever use only one classification. When we talk about, yeah, this is a simple fistula, so one understands intersphincteric होएगा या ये transsphincteric low होएगा. Low. Though again that same word comes in. It's a low fistula, or it's a high fistula, or it's with an abscess. So in practice, what we use is a combination of these. I personally still follow the Parkes classification, which is easy for everybody to understand. Thank you very much.
It's been a very good simplified way of explaining. Any questions from the postgraduates? Yes.
Sir.
Why are anterior fistulas, in women especially, classified as complex?
So the point of complex is that if we do a fistulotomy anteriorly in women, it is liable to cause incontinence in them. So the anterior part of a sphincter in women is very short, and if we divide, say, 1 centimeter of the external sphincter there, it will lead to incontinence. So that was actually covered by Sir in the first lecture. Dr. Sanjay had covered it.
So Dr. Rajdeep, is there a way to prevent a fistula? How can fistulae be prevented?
You mean at the abscess stage, or the abscess doesn't form
Yes,
at all?
well, what I mean to say is fistulae occur, they're known to occur, they're one of the commonest problems that are seen. Can they be prevented? Okay,
So if we consider the etiopathogenesis, it's because when the abscess forms, if the management occurs at the abscess level and drainage occurs in the intersphincteric groove, I mean, we drain it outside before it spreads out, that's the only thing I can think of. We can prevent complex fistulas. So as long as, I don't think there's any way of preventing an abscess from forming there, except,
absolutely,
I mean, treat
absolutely.
Crohn's, screen
So it's
tuberculosis and
yes,
so on.
Dr. V.V. Agarwal, yes.
Yes, please.
I don't have any.
Give a mic, please.
No, I think I can't cite a paper, but this question is a very good question and is always in my mind when I examine patients of fistula, and history led to me believe that all fistulas can be prevented, primary fistulas, not Crohn's, tuberculosis, IBD, radiation, malignancy kind. I have found all these patients have bad or improper bowel habits. Fistula, in my opinion, always starts from three things: either a fissure during straining hard stools, or poor hygiene, or pressure on the ischiorectal area while sitting, and folliculitis, breaking of hair. So I always tell my patients to have a smooth, like in any anorectal problem.
Grade 4 fistula, I mean grade 4 fissures are known to have fistulas.
No, I mean, and all patients who give history that I used to have itching, pain at defecation, irritation, all of them have had a 6 o'clock opening and a horseshoe trap. So they always start from fissure. All patients who have this transsphincteric or suprasphincteric fistulas, I have, in my opinion, I'm just tabulating everything. So they all start with a boil in the ischiorectal fossa, pressure sore on the ischial tuberosity, or a follicular infection, bal tod. So, or dry skin. They usually have some skin problem somewhere, including hidradenitis suppurativa. So your question was whether we can prevent it, but I certainly feel that fistula is acquired because of lifestyle.
Hidradenitis suppurativa would not be a fistula, you know.
No, I'm saying
give
those
an
patients,
extension of abscess in that area.
I'm saying those
they are more likely
they have
to have
skin conditions.
Sure.
So you take history, examine their armpits and other areas. These obese patients with acanthosis nigricans, I find most of the fistula patients who have transsphincteric, they are either obese or they have thick skin or they have a dry skin or I have a hydradenitis or I have acanthosis. I have yet to see a patient who does not have these things and have a transsphincteric fistula.
Thank you, sir. No, yeah,
So
sir,
food for
please.
thought.
With due respect to Dr. Agarwal, we are actually talking about cryptoglandular fistulas.
Yes.
What he's talking about is a small abscess in the ischial fossa
Which can
because of
spread to that
bath
area, yeah.
That is not a fistula actually, and that is not a cryptoglandular fistula. A hydradenitis is not a cryptoglandular fistula.
They form a fistula.
Cryptoglandular fistulas, really, can we prevent them? Nobody knows actually. And fissure, with the fissure which fistula comes, that is not a cryptoglandular fistula, that is just a fissure-fistula complex that is very, very superficial, and that is in the subcutaneous plane, that can be even drained without giving any division to the internal sphincter, so that is probably not there. But yes, few cases may go deep, of course.
They form intersphincteric.
Yes.
No, they don't form intersphincteric abscesses, they are usually subcutaneous, sir. Intersphincteric
So,
abscesses
but
are
this is
always...
just to incite a lot
Yes,
of thought process into it as to
intersphincteric
even-
what is fistula? Just give me one line answer.
between two.
What is vis-a-vis perineal abscess and fistula? Give me two-liner answer.
Fistula is always infection starting the IS space.
Perineal abscess is an acute sepsis, and fistula is a chronic sepsis which has not been drained well either by the nature or by
And
the
it
surgeon.
must have an epithelialized tract which
That will
is.
become because that any abscess which has not been drained well by the surgeon or by the nature leads to fistula.
So for postgraduates, it's an epithelialized tract that connects a mucosal cavity to the exterior or to another mucosal
those are the
cavity.
characteristics of a
Must.
fistula tract everywhere, anywhere in
So
the body.
going back to
So that is the reason that if you have an acute sepsis, very valid answer given by the Dr. Preet Agarwal, that in a very early infection, if you have only cryptogland gland infection called as cryptitis, there in few cases they have seen, and we have also seen, that a patient comes early, you put the patient on antibiotics, and that patient gets resolved of his cryptitis, and probably you are preventing a fistula in that case. Otherwise, per se, can you prevent a fistula? Open question.
So going back to Professor Rajdeep again, sir, is there one size fits all kind of an incision for drainage of a perianal abscess to prevent complicated fistulae from happening? Can we make one incision of this kind which can drain most of these spaces to be able to?
And that will depend on the site of the abscess, no? For
So
historectal or
we kind of did a
abscess.
thesis also on it, and it was like if you make a radial incision that starts from the perianal area going outwards, and you open the three spaces in all cases of perianal abscess, the submucosal as well as the intersphincteric and beyond that, and you pack all three of them individually, chances of complicated fistulae forming later after drainage of, I mean,
No,
we
my
did have good
concern,
results in it, and if someone else has experienced it with it, we'll be
But
happy
if you are
to.
opening up an area which is not infected, are you not introducing
No,
infection
that's
in
a
that area?
small incision with just about a 3 centimeter incision, which
You're
anyways,
opening up the spaces which are not infected. You say open them in
So-
all cases.
yes, all cases.
So I really would have concerns with that, because in abscess we tend to drain
Because-
only the area which is involved.
Would anyone else
principle
have
area.
anything to talk about
From
it?
the literature, we understand that all abscesses doesn't lead to fistula.
Yeah.
That's very
50%.
true. Only few of the abscesses which will lead to fistula,
only an
even
abscess
after
will lead
drainage.
to- only
Yes,
an abscess
will lead to fistula. Yes,
Fistula cannot be there without an abscess preceding it.
yes. So if we want to say that yes, if we drain it well, an abscess in its origin, yes, you can prevent a fistula. That's the answer.
prevent the
Yes, that is. Yeah. But prevention of an abscess.
I hope
really-
I'm not over encroaching onto
That
time,
is
but
why
I
we
thought
try
we
to
have
see-
residents sitting here.
Per se,
and-
prevention of an abscess, honestly, we don't have any answer.
So now going back to the fact that must you wait for fluctuation to appear
No,
for
no, no.
abscess to be
No,
drained?
no.
I would want Professor Rajdeep to speak about it
definitely
for.
not. I mean, that's
Yeah.
a very old
So-
dictum that we don't wait for fluctuation to
Yes.
appear.
So
if
we
there is
don't
pain,
wait.
goes for some
Right,
sort
so
of
this should be very,
investigation.
very clear to everybody. Now, if a patient comes to you in emergency with severe pain in the perianal area, how should a resident go about it? One is digital rectal examination to rule out a submucosal abscess. You look for brawny induration. If you find brawny induration, what do you do? What incision should you make?
So,
Pain may be because only on sitting.
Or we will let Professor Rajdeep answer, he was there. Yeah.
so the point is, I know because Dr. B.V. Agarwal can order
he
an
will-
MRI immediately,
yes,
and he will
yes.
get an MRI. We can't get it. So that's, I think, the crux of your question.
Yes.
So we rely mostly on the clinical, and if there is a suspicion, we still give put a needle first, aspirate. If there's pus, we go for it an incision.
So in these times of minimal
Or
access
ultrasound we are
surgery,
getting now.
are you still practicing cruciate incisions or have you given them up?
That went usually yes. Cruciate
We
incisions
still do
are
practice
given.
liberal
Yes.
drainage is good enough
the most
unless and
important.
until you have access to multiple imaging facilities
Yeah.
and the patient is willing to go in for. Sir, Dr. Agarwal, please, you were
Tend
saying
to
something.
be near the
I'm
inner
saying
location.
most of these patients won't even have a pain in perineum. We get a lot of patients referred from neurology, back pain and pain on sitting. Chronic ischiorectal abscesses, even Brownian induration may not be there. A good digital rectal examination showing you bogginess on the lateral wall of the rectum.
Or tenderness.
MRI will not be necessary, but MRI is done to document and now communicate informed consent process with the fistula.
No, I
Now-
agree. If available, it should be done.
So one last question. Any dif-
May I add something to it, ma'am?
Incision should be avoided because you can turn an intersphincter into a transfer.
So that's what I was, the second part of my answer, that I try to keep as near the anal canal opening as possible. So I don't make a large fistula like that. Okay? Don't open up the
So
anal.
any differential diagnosis you may want to suggest? This, yeah, any differential diagnosis for fistula in anal?
The cause may be different. So the causes for fistula may be various, which have already been
So
discussed.
we need to clearly define, I mean, it's like if you get something, say, in the natal cleft, to straight away call it a pilonidal sinus, you know, or to call it a, is it a complicated kind of a fistula? And sometimes multiple sinuses in the thigh and distant sinuses in the gluteal area may have origin in the
We've all seen
anus and
fistulas in the
yes.
abdominal wall
Abdominal
also.
wall, true.
We have seen a lot of things
Yes.
opening everywhere, but yes, we can't straight
And
away
for
call it a fistula.
postgraduates, again, if you find multiple openings, taking a biopsy from one of them is a must to be able to rule out.
So
I would-
usually if there is a single fistula in the perianal region, I usually do not ask for a biopsy at the initial setting. When we are doing a fistulotomy, yes, that's fine. But if there are multiple, then yes, I do it.
Thank you, sir. We'll just take a last comment from Dr. Kamal Gupta, please.
Yeah, actually, ma'am, whatever you asked, I would like to add few things. The paper has yet not been published, but it is 2022 Springer textbook. They have defined 5 prototypes. Number 1 is fissure, associated with fistula. I may not remember all the 5, it's slightly rustic, this thing. Secondly, ma'am, as Dr. Agarwal has said, burning and itching is one of the factors which is associated with fistula formation. Hidradenitis suppurativa with is another prototype, and formation of a perineal abscess or pated, that is another type. Coming to radial versus crucial incision, 2023 guidelines, they are totally against the previous practice parameters of American Society of Colorectal Surgeons. If you read Standard Corman textbook, very clearly mentioned there are no loculi. But 2023, they say loculi are present in any abscess. Secondly, when we talk about MRI, the most important thing is, even in a perianal abscess, to rule out whether it's a communicating or non-communicating fistula. So if it is a communicating, which may be present in almost 50% of the cases, then the idea is please drain the abscess and go for primary fistulotomy if possible. So these are the very clear-cut guidelines for all the residents, in my opinion.
Thank you so much, sir. And I think for the interest of time, okay.
In your book you have written that loculi should not be broken because there are some nerves which get damaged. So what's your take on that?
Sir, actually, when I started writing the book, that was based on my teaching of Corwin. Now I have quoted you 2023. My textbook of Springer, which you are talking, that was released in 2022. But these are the latest guidelines. And very recently when I operated one patient, it was when I had put a finger, then I realized loculi are there. And loculi are there, and if you don't break the loculi, chances of recurrence are much higher. And secondly, I will just add one line to it, that when you are breaking the loculi, don't be forceful. Then you are breaking the branches of the inferior rectal branches of the pudendal nerve, which can lead to paresthesia. So very, very clear on that.
Thank you, sir. Thank you, Dr. Rajdeep, sir.
Thank you.
Thanks for a very nice clinical discussion at the end of the session. So we go to the next session.